Welcome to the April 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the April issues of the journal, as well as commentaries by Dr. David S. Rouge on the article entitled Minimally Invasive Osteosynthesis with a Bridge Plate versus a Functional Brace for Humeral Shaft Fractures, a Randomized Controlled Trial, and Dr. David Ring on the article entitled Depression and Patient-Reported Outcomes Following Total Shoulder Arthroplasty. Be sure to check out this month's Current Concepts Review article on Management of ACL Injuries in Children and Adolescents by Drs. Peter Fabricant and Maninder Coker. The authors point out that children and adolescent athletes constitute the largest demographic of patients who sustain anterior cruciate ligament ACL tears, and the frequency is increasing. In ACL-deficient children and adolescents, continued symptoms of instability can result in progressive meniscal and cartilage damage as well as arthritic changes. Given the perils of non-operative treatment of complete ACL tears in children and the necessity of respecting growing physes, the authors describe several physial-sparing and physial-respecting ACL reconstruction techniques that have been developed for use in skeletally immature patients to minimize the risk of growth disturbance with favorable clinical outcomes. In this issue, JBJS.org presents a new image quiz, a 74-year-old woman with worsening limp in the right lower limb. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Minimally Invasive Osteosynthesis with a Bridge Plate versus a Functional Brace for Humeral Shaft Fractures by Dr. Fabio Teruo Matsunaga and Associates. Investigation performed at the Division of Hand and Upper Limb Surgery, Department of Orthopedics and Traumatology, Universidade Federal de São Paulo Escola Paulista de Medicina, São Paulo, Brazil. Non-operative treatment has historically been considered the standard for fractures of the shaft of the humerus. Minimally invasive bridge plate osteosynthesis for isolated humeral shaft fractures has been proven to be a safe technique with good and reproducible results. This study was designed to compare clinical and radiographic outcomes between patients who had been treated with bridge plate osteosynthesis and those who had been managed non-operatively with a functional brace. A prospective randomized trial was designed and included 110 patients allocated to one of 2 groups: surgery with a bridge plate or non-operative treatment with a functional brace. The primary outcome was the Disabilities of the Arm, Shoulder, and Hand DASH score at 6 months. The score on the Short Form 36, SF36 Life Quality Questionnaire, Complications of Treatment, Constant Murley score for the shoulder, pain level, and radiographic results were assessed as secondary outcomes. Participants were assessed at 2 weeks, 1, 2, and 6 months, and 1 year after the interventions. The mean DASH score of the bridge plate group was statistically superior to that of the functional brace group only at 6 months. The bridge plate group also had a significantly more favorable non-union rate, 0% versus 15%, and less mean residual angular displacement seen on the anterior-posterior radiograph, 2.0 degrees versus 10.5 degrees. No difference between the groups was detected with regard to the SF36 score, pain level, constant Murley score, or angular displacement seen on the lateral radiograph. Conclusions. This trial demonstrates that compared with functional bracing, surgical treatment with a bridge plate has a statistically significant advantage of uncertain clinical benefit with respect to self-reported outcome, DASH score at 6 months, non-union rate, and residual deformity in the coronal plane as seen on radiographs. Next, you'll hear a commentary by Dr. David S. Rouge on the article entitled Minimally Invasive Osteosynthesis with a Bridge Plate versus a Functional Brace for Humeral Shaft Fractures, a Randomized Controlled Trial.
This is Dr. David S. Rouge providing commentary for the April 2017 JBJS podcast. I will be providing commentary on the article entitled Minimally Invasive Osteosynthesis with a Bridge Plate versus a Functional Brace for Humeral Shaft Fractures, a Randomized Controlled Trial. The title of my commentary is An Excellent Study of Operative versus Non-Operative Treatment of Humeral Shaft Fractures. This article is an excellent attempt to address the clinical dilemma posed when a patient presents with a closed humeral midshaft fracture. In an era of increasingly aggressive surgical management of common fractures, we are frequently faced with the difficult task of predicting how patients will fare in the long term with non-operative management. Experience has demonstrated that the chance of achieving union with a functional brace is anywhere from 77% to 100%. Indeed, in this study by Matsunaga et al., non-operative measures achieved union in 85% of patients. Operative management with a traditional open anterolateral approach is associated with blood loss, a risk of radial nerve palsy, infection, and a frequently substantial and noticeable scar. The technique of minimally invasive osteosynthesis, while previously reported on, has not gotten widespread attention in many parts of the world. The technique offers many potential advantages over the traditional anterolateral approach, including less blood loss, shorter incisions, and less muscle trauma. Matsunaga et al. Reported a 100% union rate and a low complication rate with this technique. The real question that this study raises is, what are the drivers of increasingly aggressive management of humeral fractures? One driver would be better patient-related outcome scores after operative treatment. The current study, while demonstrating a slightly higher disabilities of the arm, shoulder, and hand, the DASH, score at 6 months, did not show a difference of greater than 10 points, which has been considered to be the minimally clinically important difference between two groups. A second driver would be a wish to avoid the complications associated with non-operative management. Certainly, the current trend of treating scaphoid fractures with immediate surgery reflects a concern about successful management of the difficult problem of non-union of that bone. In this study, 7 patients, or 13%, had a humeral shaft non-union, and 1 had a humeral shaft malunion after non-operative management. All were managed successfully with conventional surgical treatment of the non-union, with perhaps the greatest complication being the time that the patient spent undergoing brace treatment. Although this study does not provide compelling evidence to support routine operative intervention, it does take the first step in the identification of which patients will benefit from early operative management. While the analysis of the non-operative group did not show a correlation between non-union and the risk factors of obesity and large chest mass, which are traditionally associated with unsatisfactory results, subsequent studies may elucidate which factors may predispose patients to early operative treatment. Finally, despite the current landscape of healthcare, the authors did not examine the cost associated with non-operative management of a humeral shaft fracture, which can frequently take months to unite. While the surgical costs can be estimated, the ability of the patient to return to employment may be an important factor in patient decision-making. The exact time to union and the patient's return to employment were not evaluated in this study, and without these data, the cost of operative versus non-operative management cannot be calculated. The authors are to be congratulated on completing an excellent, well-designed, and well-controlled study, and providing a critical first step in identifying the optimal management of this common fracture.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Randomized Controlled Trial of Interscalene Block Compared with Injectable Liposomal Bupivacaine in Shoulder Arthroplasty by Dr. Serena Namdari and Associates. Investigation performed at the Department of Orthopedic Surgery, Rothman Institute, Sidney Kimmel Medical College at Thomas Jefferson University, Philadelphia, Pennsylvania. Shortcomings of interscalene brachial plexus blockade include technical failure and rebound pain. Bupivacaine liposome injectable suspension, a sustained-release preparation, is used for surgical site administration. The purpose of this study was to evaluate these two postoperative pain management strategies in patients undergoing shoulder arthroplasty. In a non-blinded, randomized controlled trial of participants undergoing primary shoulder arthroplasty, patients were randomized to interscalene brachial plexus blockade or intraoperative soft tissue infiltration of bupivacaine liposome injectable suspension. The primary outcome variable was morphine equivalent units consumed over the first 24 hours postoperatively. Secondary outcomes included morphine equivalent units consumed intraoperatively and a visual analog scale for pain at 0, 8, 16, and 24 hours. 78 patients were randomized to interscalene brachial plexus blockade treatment, the blockade group, and 78 patients were randomized to bupivacaine liposome injectable suspension treatment, the suspension group. The mean total postoperative narcotic consumption and standard deviation over 24 hours after the surgical procedure was 14.8 plus or minus 11.3 morphine equivalent units in the blockade group, compared with 14.4 plus or minus 16.8 morphine equivalent units in the suspension group. Intraoperative narcotics were significantly lower in the blockade group compared with the suspension group. The mean visual analog scale pain score was significantly lower in the blockade group than in the suspension group at 0 hours postoperatively and at 8 hours postoperatively, but it was not significantly different at 16 hours postoperatively. The visual analog scale pain scores were significantly higher in the blockade group compared with the suspension group at 24 hours postoperatively. Conclusions. Patients treated with bupivacaine liposome injectable suspension required an equivalent amount of postoperative narcotics and greater intraoperative narcotics compared with patients treated with interscalene brachial plexus blockade. Although interscalene brachial plexus blockade provided improved pain scores for the first 8 hours after the surgical procedure, pain scores were worse at 24 hours. The optimal postoperative pain regimen for shoulder arthroplasty and the cost-effectiveness of analgesic techniques require further investigation. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Depression and Patient-Reported Outcomes Following Total Shoulder Arthroplasty by Dr. Brian C. Werner and Associates. Investigation performed at Sports Medicine and Shoulder Surgery, Hospital for Special Surgery, New York, New York. Recent studies have found that depression is associated with increased pain and impairment following lower extremity arthroplasty. However, this association has not been investigated for total shoulder arthroplasty. The objective of this study was to investigate the association between depression and patient-reported outcomes following total shoulder arthroplasty. A prospectively collected institutional registry was queried for consecutive patients who underwent total shoulder arthroplasty for osteoarthritis from 2007 to 2013, with baseline and minimum 2-year postoperative American shoulder and elbow surgeons ASES scores. Revision procedures and total shoulder arthroplasty for diagnoses other than osteoarthritis were excluded. Patients with a preoperative diagnosis of depression formed the study cohort. Control patients without a diagnosis of depression were matched to the study patients by age and sex in a 2-to-1 ratio. Baseline characteristics and patient-reported outcome measures were compared between groups, as were minimum 2-year patient-reported outcomes and change in patient-reported outcomes. A multivariable regression was performed to investigate the independent effect of depression on improvement in ASES scores. Except for the short Form 12 Mental Component Summary SF12 MCS scores, there were no significant differences in baseline characteristics between study patients and controls. There was a significant improvement in the ASES score for patients with depression and controls. Patients with depression had significantly lower final ASES scores and less improvement in ASES scores and SF12 Physical Component Summary scores, as well as lower satisfaction levels at 2 years. However, the latter difference did not reach clinical importance. Depression, p equals 0.018, was an independent predictor of less improvement in ASES scores. Conclusions. Patients with a diagnosis of depression should be counseled that they will experience a significant clinical improvement from baseline after total shoulder arthroplasty. A preoperative diagnosis of depression is an independent predictor of significantly less improvement in ASES scores following total shoulder arthroplasty. However, this difference does not reach clinical importance and should not discourage patients with a clinical diagnosis of depression from undergoing total shoulder arthroplasty. Next, you'll hear a commentary by Dr. David Ring on the article entitled Depression and Patient-Reported Outcomes Following Total Shoulder Arthroplasty.
I'm Dr. David Ring, providing commentary for the April 2017 JBJS podcast. My commentary addresses the article entitled Depression and Patient-Reported Outcomes Following Total Shoulder Arthroplasty. The title of my commentary is Resiliency is Good for You. The study Depression and Patient-Reported Outcomes Following Total Shoulder Arthroplasty makes good use of a prospective registry that recorded diagnosed major depressive disorder and also measured patient-reported outcomes. A recorded diagnosis of major depressive disorder was associated with less improvement and lower final scores on questionnaires measuring symptoms and limitations in a comparison of matched cohorts without a diagnosis of major depressive disorder. These findings match our intuition that even people with lower mood appreciate having their disease treated, and that the happier you are, the more comfortable and capable you are in spite of disease. This type of study may simply put numbers on common sense. The happier you are, the less things bother you. The more important thing is that such studies draw attention to the potential benefits of attention to stress, distress, and less effective coping strategies. We can probably take better advantage of opportunities to help coordinate care that optimizes both pathophysiology and resiliency. Resiliency is the ability to recover from or adjust to misfortune or change, something I refer to as comprehensive care. For every patient with a diagnosed major depressive disorder, there are likely one or more additional patients with an undiagnosed major depressive disorder, and several others with substantial symptoms of depression. A diagnosis of major depression implies patient insight and active treatment. To get a sense of the magnitude of potential missed opportunities, consider the recent study of more than 40,000 people who had depression screenings in primary care. More than 8% met a threshold for a potential diagnosis of major depressive disorder, with fewer than 30% of them receiving treatment. And among all adults under treatment for major depressive disorder, only 30% had depressive symptoms, meeting the threshold usually used to estimate this diagnosis. In other words, major depressive disorder is either overdiagnosed or inadequately treated in many patients, and thousands of others have underappreciated and undertreated major depression. This is consistent with a study in my upper extremity surgery practice that found about 1 in 8 patients met criteria for an undiagnosed major depressive disorder. It may be time for a different approach. Labeling people as depressed or not depressed seems arbitrary, artificial, counterproductive. We can all attest that symptoms of depression and anxiety occur on a continuum. All of us have some symptoms of depression and some symptoms of anxiety every day. Labels can stigmatize and shame, and they may decrease the appeal of working on resiliency. There are many advantages to addressing resiliency on its continuum. Symptoms do not bring a person to the doctor. We seek care when a symptom becomes a concern. It seems safe to assume that everyone seeking our care is at least a little bit unsettled. Evidence is mounting that everything we do to normalize and ameliorate those feelings enhances resiliency, which then reduces symptoms and limitations and optimizes health. We talk a lot about patient expectations, but when a person is dissatisfied with a surgical procedure, is that not more likely due to an error in diagnosis? I think dissatisfaction may belie undiagnosed and undertreated stress, distress, and less effective coping strategies. These may be missed opportunities for improved resiliency and improved health. In this context, talking about patient expectations feels uncomfortable. It seems as if we are blaming the patient for the illness. Counseling depressed patients that they may not do as well as non-depressed patients sounds like something we do for ourselves. I would like to stay focused on how we can help people get and stay healthy. It was no surprise that total knee arthroplasty outperformed non-operative care in a recently published randomized trial comparing the two. The surprise was how much people in the non-operative group improved. The ability to improve without intervention is the manifestation of the power of resiliency. Resiliency is the embodiment of all the non-technical things that we do for people, taking genuine interest in them, restoring meaning, purpose, and hope, and motivating them to return to their daily routine. With time for reflection and revitalized self-efficacy, people need a lot less treatment to achieve comparable health, and they recover more rapidly after injury or a surgical procedure.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled "Females with Unexplained Joint Pain Following Total Joint Arthroplasty Exhibit a Higher Rate and Severity of Hypersensitivity to Implant Metals Compared with Males" by Dr. Marco S. Caicedo and Associates. Investigation performed at Rush University Medical Center, Chicago, Illinois. Recent studies indicate that females demonstrate an increased risk of experiencing adverse local tissue reactions, aseptic loosening, and revision after primary metal-on-metal hip resurfacing arthroplasty compared with males. The underlying biological mechanisms responsible for sex discrepancies in implant failure remain unclear. In addition to anatomical and biomechanical sex differences, there may be inherent immunological disparities that predispose females to more aggressive adaptive immune reactivity to implant debris, i.e. metal sensitivity. In this retrospective study, the authors analyzed sex-associated rates and levels of metal sensitization in 1,038 male and 1,575 female subjects with idiopathic joint pain following total joint arthroplasty, TJA, who were referred for in vitro metal sensitivity testing. Females demonstrated a significantly higher rate and severity of metal sensitization compared with males. The median lymphocyte stimulation index, SI, among males was 2.8, compared with 3.5 among females. 49% of females had an SI of 4 or greater, compared with 38% of males. And the implant-related level of pain was also significantly higher among females compared with males. Conclusions. In a select group of patients who had joint pain following total joint arthroplasty and no evidence of infection, and who were referred for metal sensitivity testing, females exhibited a higher level of pain and demonstrated a higher rate and severity, as measured by lymphocyte SI, of metal sensitization compared with males. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.